Good afternoon, everyone, and welcome to updates on women's health and exclusive CME event. Thank you so much for joining us here this afternoon. Hope some of you are enjoying your lunch today. All good? All right. So this event is presented by the Obstetrical and Gynaecological Society of Singapore, OGSS, and co-organized by InnoQuest Diagnostics, Abbott Laboratories, and LifeStrands Genomics. My name is Dr. Navenia Nishel, and I am the Group Clinical Affairs Manager at Pathology Asia. It is my privilege to be your MC for this afternoon's CME, and later to moderate the panel discussion with our distinguished faculty. This CME is designed to give us more than just theory. It is meant to be practical, to translate science into what we can bring back to our daily practice. Today, we will cover 3 critical aspects of women's health. Number 1, cervical cancer prevention and HPV genotyping, advancing the way we stratify risk and manage patients. Breast cancer screening, addressing the ongoing challenge of early detection and population strategies. Genetic advances in prenatal testing, how far we've come in non-invasive testing and where it may take us in the near future. So what makes today special is not only the science, but the interdisciplinary expertise in the room. We have gynecologists, breast surgeons, genetic scientists, health screeners, and primary care providers. A true reflection on how women's healthcare is best delivered, that is collaboratively. We know the statistics. Cervical cancer remains preventable, yet uptake of screening lags. Breast cancer is still the most common cancer in women, and outcomes hinge on early detection. Prenatal care is evolving, but counseling and interpretation remain complex. So my encouragement for all of us here today is this. Let's not only learn the updates, but also think about how we can implement them. How do we improve patient conversations? How do we close practice gaps? How do we use new tools in ways that make care more efficient and more accessible? On that note, let's begin our program. Please allow me to introduce our first speaker for today, Dr. Weng, obstetrician and gynecologist and oncologic surgeon at STO+G practice. Dr. Weng graduated from the National University of Singapore in 2009. She completed her obstetrics and gynecology training with SingHealth and was a best resident every year. She is a member of the Royal College of Obstetrics and Gynecology UK and a fellow of the Academy of Medicine Singapore. Since 2017, she has been a gynecologic oncology consultant at KK Women's and Children's Hospital, skilled in minimally invasive and open surgeries. She is a certified colposcopist and active in medical education. As a mother, she advocates holistic women's healthcare from puberty to menopause. She won the SingHealth Gold Service Award in 2022 and the Star Award in 2023. Today, she will be presenting on advances in extended HPV DNA genotyping, including guideline comparisons, case studies, and future applications. Please join me in welcoming Dr. Weng.
So thank you for the very kind introduction, and I thank all of you to be here today for this talk. Thank you to the organizers, OGSS, InnoQuest, Abbott, as well as LifeStrands for the invitation to speak today. As for my introduction, I'm here to talk about extended DNA genotyping. All right, and this is my presentation. I think I'll first start off with talking about HPV, human papillomavirus. It's going to be a bit dry to talk about dry facts of the virus on a Saturday, so I just thought I'll zoom in on interesting facts, some questions that patients often ask us in the clinic, and some of the interesting facts of the epidemiology of transmission of this virus that led us to the guidelines that we have come up with to guide screening as well as onward referral in patients today in Singapore. Next, I'll be speaking about HPV extended genotyping, as well as the specific causal attribution to invasive cervical cancer as well as cervical precancer. Management of results, we have our SCCPS guideline that has been just updated this year, and I'll be sharing a little bit about results management. Taking a broader overview to look at what other countries such as the UK, the US, as well as Australia do, and comparison with the difference between them and us in Singapore. I'll be going through a patient of mine that I managed, a case study just to illustrate a patient's journey from screening in the primary care setting all the way to onward referral for colposcopy, treatment, as well as subsequent follow-up, just to show how what the test that we do and how it influences a woman in her diagnosis and management. And I will end up by sharing about how HPV extended tapping can value add to our clinical practice and to lead us in future directions, be it research, policy making, etc. Alright, so I think I'll first start with talking about what HPV is. So HPV stands for human papillomavirus. As we all know, it's a very common DNA virus. 80 to 90% statistically of sexually active males and females will eventually be infected by HPV in their lifetime. And this is because the mode of transmission, as we know, is from direct skin-to-skin contact during intimate sexual activity. All right. So I guess that's why built into our local guidelines and universal guidelines, women that are single, they are not sexually active, have never been before, actually do not require cervical cancer screening. In the Singapore context, we recommend screening to start from 25 years old, as long as women are sexually active. There are often, there are more than 200 subtypes of HPV viruses, and they can be divided into those that cause cutaneous or skin manifestations, as well as those that can cause mucosal manifestations. Cutaneous or infection of the skin can cause common warts that we find on hands as well as feet. Mucosal are those that infect the genital tract, the vagina, the vulva, the cervix. And these can be divided into high versus low risk subtypes. The low risk subtypes, or type 6 and 11, are those associated with genital warts. The high risk subtypes, and the most well-known of which is type 16 and 18, which can, if persistent, can cause changes on the cervix leading to precancer as well as cervical cancer. So this is natural history sequence is very important in the development of invasive cervical cancer. If let's start off with initial HPV infection, an important part of this is virus persistence in the body over time in the genital tract, which leads to subsequent progression to CIN2, CIN3, which is considered pre-invasive, precancer, and subsequently invasive cervical cancer. So I think our main goal is to prevent cervical cancer, and hence screening treatment of CIN2 and 3 in a bid to reduce and to stop cervical cancer from coming up. An important point to note is that persistent infection is required for progression. Transient infections rarely result in mutation. So a transient infection, say in a young 20-plus-year-old who just started becoming sexually active, there's a very high chance that she can clear the virus without any sequelae to the cells in her vagina, vulva, and cervix. And something important that we found is that persistent detection of the same high-risk genotype over time is strongly associated with high-grade lesions as well as cervical cancer. So it's the persistence of the same high-risk type over time that we're actually concerned about. So I think some patients do ask, what is the chance of me clearing the virus spontaneously? And we do know that the clearance of HPV is due to cell-mediated immunity by our body's own immune system. And the rates are actually pretty good. So in a year's time, so if a young, say 20-year-old patient started becoming sexually active and she got this virus from her partner, in a year's time, 60 to 70% of patients actually manage to overcome this with their own innate cell-mediated immunity and clear this virus from the system. This number goes up to almost 90% 2 years later. Alright, so I think this is one of the key points as to the guidelines in Singapore. So if you recall, if we do detect the presence of HPV non-16-18 positive, a reflex pap smear or cytology should be done. If the cytology is negative, the recommendation is to repeat testing in a year's time. The rationale behind that is the majority of these patients, if it was a new infection that we found, will have cleared the virus by then. And if the HPV becomes negative then, and the pap smear remains normal, then we can reduce anxiety by onward referring this patient to colonoscopy. Because once again, persistent infection is what we're concerned about. Transient infections usually cause the harm. The next question is, are all HPV subtypes equal? So there are more than 150 that I've shared. And I think that an important point is that no, they are not all equal. All right. In terms of persistence, so we do know that HPV 16 clears more slowly than the other genotypes. And something interesting is that if a patient has infection with more than one strain of the virus, multi-type infections clear more slowly as well. I was talking to Dr. Cindy over there, and she said that yes, sometimes we see patients with the royal flush of results. You know, they get referred to us, HPV 16, 18, non-16, 18, everything is positive. And at the back of our minds, we do know that these patients are slightly higher risk of dysplasia and cancer, especially if this is a persistent result that we see. I apologize that this slide is a little bit busy and a bit small, but essentially it is a chart from a paper done back in 2007, and it shows the clearance rate of different strains of HPV over time. We do see that at 6 months, all right, and it being not equal. So at 6 months, the clearance of HPV 16, 31, 33 is significantly lesser than the other strains, for example, HPV type 68. This trend persists at 18 months or 1.5 years later, and we do see that the clearance of HPV 16, 31, and 33 remain more persistent than the other strains. For example, HPV 68, as well as HPV 39, of which majority, up to almost 90%, are cleared from the system. So I guess this next question is, so what are some of the factors that influence whether we're able to clear this virus from the system? And I think an important key point is the host immune status. So systemic immunosuppression, for example, patients diagnosed with HIV, or those with the use of immunosuppressive medications, and I apologize for this typo. So glucocorticoids are no longer regarded as significant immunosuppressive medications. Instead, for example, things like methotrexate, calcineurin inhibitors like tacrolimus, biologics are the ones that we're more concerned about. So glucocorticoids alone do not classify as significant immunosuppressive medications. So in all these patients, their immune system is suppressed, and the chance of them being able to mount an immune response to clear the virus is less. And therefore, built into our local guidelines is the fact that these patients who fall under this category require a little bit more closer monitoring. From 25 to 29, these patients we recommend yearly Pap smears, and more than 30 to 69, we recommend 3-yearly HPV screening instead of 5. And as a result of this knowledge that these patients are less likely to clear the virus infection. The HPV genotype, as I shared previously, matters. HPV 16, we do know, is less likely to be cleared from the body compared to the other subtypes. And again, single versus multi infections at the same time. Single types are usually more easily cleared than if you are infected with different strands of the virus. Co-infections. So if patients have co-infections with other sexually transmitted infections, such as herpes simplex type 2, chlamydia, or there is a dysbiosis of the vaginal microbiome, such as bacterial vaginosis, again, it promotes persistence by modulating the local immunity and ongoing inflammation in the genital tract. So for patients that do have symptoms of STI, it would be good to screen them and treat them because these are some risk factors that can make them more prone to persistent infections. Certainly what we teach our medical students to apply today. So for the age of patients, smoking, all right, drinking, including long-term contraceptive use, high parity, poor nutritional status, low socioeconomic status, all these are risk factors in persistent infection and therefore cervical precancer as well as cancer. Certainly, treatment of cervical lesions is often followed by higher HPV clearance compared with observation alone. But an important point to note is that we don't treat patients with excision or ablation based on their HPV status alone. The intention of treatment is for cervical dysplasia, right? And we do find that after treatment of cervical dysplasia, the rate of clearance of HPV is slightly higher. And this is the rate of clearance after dysplasia treatment. So not spontaneously, but with intervention. For treatment with say CIM 2 to 3, at the 3-month post-treatment mark, we do find that 20+% of the HPV is cleared, and this number slowly increases with time. Certainly, there are some factors that affect the clearance, and the first of which is the therapy that we chose for the patient. Is it an excision therapy such as sleep or cone biopsy, or an ablative treatment such as laser ablation? So I think excision is associated with a higher risk of clearance compared to ablative treatment. Margins, all right. So often if we do excision, the pathology report comes back as radial margins, endocervical, ectocervical margins. If the margins are negative, it's related to a higher risk, higher chance of HPV clearance compared to a positive margin. Certainly age of the patient as well. Younger patients tend to clear the HPV at a higher rate than older patients. Again, related to the immune response and immune ability to clear. And therefore, I think built into this as well in our local guidelines is the fact that after treatment for patients, at the 6 and 1 year mark, we will do tests for cure. And with tests of cure, we do both Pap smears as well as HPV to find out what is the status of the patient after treatment is instituted, so that it can better guide our long-term management of these patients. Some patients do like to ask, they get diagnosed with HPV and they come to my clinic and they are actually more concerned about their partners than themselves. So I thought this is just something interesting to look at. What's the transmission rate from males to females versus females to males? And certainly, I think at this point in time, we do screen women for HPV, we don't screen men. And because men, I think the test is not readily available or accurate screen for HPV, and men don't have cervixes or at a risk of cervix precancer as well as cancer. Interestingly, male to female transmission is slightly lower than females to males. And this is among sexually active discordant partners, all right? And there's no major difference across the subtype, which is more likely to pass on. Just a quick word about HPV extended genotype. So on the left side, no genotyping is whereby we just detect whether a patient has HPV or not. So the answer is yes or no. Limited genotyping is when we stratify out 16 and 18, and the other high-risk 12 subtypes are as a basket of non-16, 18. And I think this is quite a prevalent test that's available locally. Extended genotyping, and the concept of which is to further stratify this others non-16, 18 into different groups. For example, the one on the extreme right, stratified out will be 16, 18, 45. As a group, 31, 33, 52, and 58. And the last group of 35, 39, 51, 56, 59, 66, and 62. And I think if you do look at the top component of the first 4 rows, these are the viruses that are covered by a vaccine, the 9-valent vaccine. And I think that might be something interesting to look at. I apologize for this small chart, but I thought this was an actually interesting chart that was taken from a study recently published in 2024 in the Lancet Journal. This is actually from a systematic review or analysis of the global causal attribution of HPV virus genotypes to invasive cancers. So if you look at the horizontal axis, it's the prevalence of HPV in women, and on the vertical axis is this entity known as AF logarithmic scale. So AF stands for attributable fraction, which is an epidemiological measure that quantifies the proportion of disease related to that risk factor or exposure. All right, so if you do look at the top right-hand corner, HPV 16 is gray and above, far right and far top of the chart. So this tells us that HPV 16 is both prevalent and causes a large proportion of cervical cancer, invasive cancer. So 16 and 18 altogether, I think they account for about 75% of cervical cancers, invasive cervical cancers. And therefore, a large disease burden is attributed to them. Slightly lower in the chart, not as prevalent, but high AF is type 18. And the third on the vertical axis will be type 45. Something interesting about type 45 is that we do know its association with adenocarcinomas as well as adenocarcinomas in situ. So I think having a type 45 for the colposcopists in the room, it's a little bit of value add to make sure that you do check the endocervix a bit more carefully and ensure that you exclude any glandular lesions, which are notoriously difficult to pick up on colposcopy. The next of which is something like type 52, so prevalent, but the AF is slightly lower. And I think these are all the subtypes that are being tested for HPV testing. In the local context, Dr. Ismail-Pratt and partners have published a paper. It's pretty old, in 2013. I thought it was just interesting to look at something from the local perspective. Because the chart I shared earlier was globally. In the local perspective as well, they looked at 5 Asian countries, including Singapore. And the data I put out on the left is HPV subtypes related to invasive cervical cancers in the local setting, and on the right is CIN 2 to 3 precancers. Okay? So similarly, we do see that the leader is type 16, type 18 for invasive cancers, and also the same numbers are appearing, 52, 33, 58, 51. Alright, so all these are quite standard and quite prevalent, as well as linked to cervical cancer and precancer, even in the local Asian setting. This is a guideline that has been published by SCCPS in conjunction with Singapore Health Promotion Board. This is the latest guideline updated just in March 2025. In the room with us today is Dr. Ina, who is the chairperson of this clinical workgroup committee, who will actually be sharing with us a small project after my talk as well. This is the latest guideline that we follow in the local context with regards to management of results and onward referral for counsel. So this is actually a guideline that's available on the SCCPS website that can be downloaded free of charge to guide our clinical management. So looking at something that's relevant to the talk today, right? So HPV primary screening is advocated for women from 30 to 69 years old, women that are sexually active or have ever been sexually active, and women who are 25 to 29, Pap smears are recommended. Precisely because I think in the knowledge that younger patients tend to have transient infections, and we don't want to cause unnecessary alarm by doing HPV testing at the early age. So for this guideline, as you can see, we start off with a HPV test. If it's negative, the patients are reassured and they return to routine screening. And the next test that they should do should be within 5 years. If the result shows type 16 and 18 positive, referral to colposcopy is warranted. And for HPV that is non-16, 18 positive, cytology trial should be done. If the cytology is normal or negative, a HPV test can be repeated in a year's time. And if it has turned negative, what we've picked up is likely transient infection, and the patient can be reassured and return to routine screening. However, if the HPV remains positive at a year's time, colposcopy is warranted, or if the immediate cytology triad shows ascus, apical cells of unknown significance, or worse, namely as high CIN1, CIN2, CIN3, glandular abnormalities, immediate colposcopy referral is recommended for further testing. A quick word about the HPV test. We did state that the HPV test needs to be registered with the Health Science Authority of Singapore. Type 16 and 18 specific genotyping is required, and the other 13 high-risk subtype needs to be detected as well in that test that is used. Taking now a more broader view about what different countries in the world are doing, this is actually taken from the UK, so NHS cervical screening program. They updated it in July this year, and they recommend actually primary HPV screening. And they start at age 25 to 64. So this is just a reference. So I think I would like to emphasize that in Singapore, we should follow the local guidelines, but just to take a look around the world, what are other countries doing? The patients get invited, and it's an opt-out testing at 25 years old if it's actually active. If the HPV test done is negative, similar to us here in Singapore, routine recall in 5 years is the next step of action. If the test is positive, cytology triage is done. And if it's HPV positive but cytology negative, they repeat it a year later. Quite similar to us, but I think that threshold for referral to colposcopy is a little bit higher. HPV has to be positive 3 years in a row before colposcopy referral is warranted in the case of NHS. And I think something interesting, and I tried to look a bit closer, but it does seem that they don't differentiate between the high-risk HPV strains, which to me is quite nice. Looking at America, there are America, I think there are more guidelines available and more choices. On the right is the American Cancer Society, and on the left is the US Preventative Task Force. So similarly, they do recommend cytology and then local testing or primary HPV testing. And with regards to the management of the results, they adopt quite a risk-based management mentality. So they triage the patients, and they actually have a web application for clinicians to enter in the results, and they help to risk stratify them to the subsequent management. So they compute it based on things like the patient's age, any previous, what does the Pap smear show, what's the HPV show, and upon keying it in, the recommendations will be given to the individual clinician. Whether it's low risk, should they repeat the testing in a year's time? Intermediate risk, either colposcopy or intensified surveillance, or high risk and immediate colposcopy and treatment as well. So in America, I think a little bit more risk-based kind of approach. This is Australia, and it's quite small, but essentially I think Australia is the closest to us here in Singapore with regards to management of the guidelines or with the results. So they do HPV tests as well, negative, which you recall, 16-18 direct colposcopy, and the non-16-18's cytology triage. So I think for the Australians, 16-18 do get a cytology triage as well. And in Australia, built into the guidelines is the allowance of HPV cells testing and subsequently what to do with the results. Okay, so I think I'll just go through a real case example just to illustrate what happens in a patient's journey so that we can have a little bit more clinical correlation to how a patient's results leads her to the next step of treatment and management. So this is my patient who is a 42-year-old female. She's married, she has 2 kids. She tells me that she has completed her family, she did ligation, menses is regular, she's a smoker, and her last Pap smear was actually done a very long time ago. This patient is unvaccinated to HPV. So following this algorithm, she went for HPV primary screening, and her results have come back as non-16-18 positive, and the cytology triage returns as ASCH. So as per the guideline, this patient underwent referral for colposcopy, and colposcopy was done. These are the pictures taken from her test, from her colposcopy test. So it's an adequate colposcopy, the swimmer coronary junction is visible, posteriorly it's obscured slightly by discharge, but it can be removed, and there are grade 2 or major findings, such as dense acidoid changes, some cause mosaicism, which are concerning for high-grade changes. So biopsy was done and sent to the lab for confirmation, and it has returned as CRN223. Right, so with this results in our mind, so she's 42 years old, she has completed family, she's a smoker, she has HPV unvaccinated. So these are some of the baseline information of this patient that we take into consideration when recommending treatment. Okay, so for this patient, I counseled her for treatment of her CRN223, and she underwent cold biopsy of the cervix. So cold biopsy of the cervix, following the guidelines, so after treatment, well, I guess there are treatment options available, be it ablation or excision, and built into the guideline is also some considerations how to best select the optimal treatment for the patient. So this patient underwent cold biopsy, and the results returned as CRN223, completely excised, no microinvasion. All the margins reported are clear, and she had an uneventful recovery. So there is a post-treatment follow-up that is required to make sure that we have solved the problem for her. At 6 months, and the first, known as the first test of cure, we do PEP as well as HPV testing for these patients. At the first 6 months, her HPV non-16-18 remained positive, but her PEP was negative. According to the guidelines, if the HPV remains positive, colposcopy is warranted, and colposcopy was done, and that was normal. At the 12-month mark, known as the second test of cure, now her HPV test has turned negative, and the Pap smear remains negative as well. I did one more test for her a year later, and both tests has remained negative. And for these patients, we can safely reassure them that the chance of them having cervical precancer or cancer has reduced greatly due to treatment and clearance of the HPV. And thus, these patients can be referred back to routine screening in the community, provided that they are compliant to attend routine screening, and there should be a strong call and recall system in case they miss that test. In addition, for this patient, I did mention that she's a heavy smoker. So as part of the recommendations, smoking cessation, as well as discussion about HPV vaccination. So as part of the society's position paper, we did have a position about whether women who have HPV infection or a history of CIN can be vaccinated, and the answer is yes. However, these women must be informed that the vaccine itself is not therapeutic, it's not meant to treat whatever HPV they have, It doesn't treat the existing CIN. The treatment was with the home biopsy. Okay, but there is still some benefit to that in terms of reducing the risk of subsequent new HPV vaccinations, and clinical follow-up is still required. Okay, so in a nutshell, I think this is the management of a patient with abnormal result throughout the course of treatment as well as follow-up and the counseling that we do around the situation. So moving to what extended genotyping, how can it value add to us? I think there is value add in terms of risk stratification to the patient, for example. Does she have, what is the subtype that she has? Certainly to the colposcopists in the room today, for those with HPV45 positive that's identified, I think we should spend more time to exclude at the back of our minds adenocarcinoma, AIS kind of lesions. If we cannot see the transformation zone, then we should be mindful to make sure we can do an endoscopic curettage, for example, to exclude these lesions. I think from a resource allocation perspective, refer to colposcopy wait times can also be better triaged moving forward. For example, if a patient with HPV, say 68, the attributable fraction is much lower. And if she has persistent HPV 68 positive versus HPV 52 or 45 positive, maybe the day can come that we can better allocate them to how long the wait time is, or how fast track that they need to, in terms of referral to colposcopy to be seen for biopsy and colposcopy. Certainly, genotype specific monitoring can in future influence vaccine policy, hopefully, right? As well as the day may come that we can tweak screening intervals depending on that. As of today and as of 2019, secondary school girls in Singapore receive free Cervarix vaccination. Cervarix is a bivalent vaccine that covers type 16 and 18. It is currently still an opt-in vaccine, so secondary school girls at 13 and 14, permission gets asked from the parents, and they do it at the school level. They get 2 doses at this young age, and for vaccination against type 16 and 18. I think moving forward, it will be interesting to see whether when these girls, and these girls are now maybe 20 years old soon, and they will start to do their cervical cancer screening in a couple of years' time, and HPV screening eventually. So I think it will be interesting to see in this population of girls who have been vaccinated at a young age, will we start to see some trends in the change of the virus subtype that they are getting? Will there be therefore any changes in the type of disease, the dysplasia rates, the cancer rates that we're seeing? And I think this is something interesting from a government health promotion board, Ministry of Health perspective, to see whether eventually we will be modifying our local guidelines as well in terms of vaccine policy as well as screening intervals. I've come to the end of my talk, and I thank you for your attention. I think at the end we do have a panel discussion, so perhaps I'll pass my time on to the subsequent speakers, and if you have any questions, I'll be happy to take them later. Thank you.
All right, thank you so much, Dr. Ho, for a very, very insightful presentation. So before we move on to the next speaker, I'd just like to channel your view on the QR codes on your table. So feel free to basically scan your QR codes and ask any questions you'd like to our doctors, our speakers here today, and we'll address it at the end of the session during our panel discussion later on. All right, so next, I would like to introduce Dr. Ismail-Pratt, Consultant Obstetrician and Gynaecologist at Athena Women's Specialist, and a key leader with the Society for Colposcopy and Cervical Pathology of Singapore. Today, she will share briefly on the EmpowerCare initiative and how it supports Singapore's cervical cancer elimination strategy. Please welcome Dr. Ida.
Hi everybody, thank you. I won't take a lot of your time, probably about 5 minutes or so. I'm just here to introduce to you a program by the Society of Colposcopy and Cervical Pathology Singapore, and this is called EmpowerCare, which I really truly believe is a powerful tool for all of us, especially for all of us healthcare workers in terms of our day-to-day clinical work. What it will do is to benefit not only our Singaporean women, but also hopefully for all the healthcare providers, it's your business as well. So, those that know me know my passion for cervical cancer prevention. My dream is no woman in Singapore should have cervical cancer. However, as we know, in Singapore, even though we are a high-income country, there are issues still that we are facing. The thing is that there are barriers, and we know there are barriers for women why they're not coming for screening. But people talk about barriers for women, but they don't talk about barriers for healthcare providers. It's also one of the things that we know is that, and we have done a survey on this, 50% of primary healthcare providers do talk to the women, have an opportunistic counseling with the women regarding cervical cancer prevention, but only less than that actually offer cervical cancer prevention for eligible women when they see the women in the clinic. Now, there's various reasons for this. One of the reasons is not knowledge. I mean, it may be a bit of knowledge, but most of the time, it's the communication skill. The problem with HPV primary screening is the fact that the HPV screening is a simple test. You can now use a self-sampling because we have introduced a workflow for it in the guideline. But the problem of offering the simple HPV test is the Pandora box that you open when you are talking about HPV to your women. There will be myriads of questions over challenging questions that we are faced, and this is informed to us by a lot of primary healthcare providers that they're not able to answer. So that's what EmpowerCare is all about. What we are hoping to do is to give healthcare providers, focusing on primary healthcare providers, first the basic knowledge which makes your strong foundation to your cervical cancer prevention management, and also to support not only your knowledge but also clinical skills and communication skills and counseling skills so that you can actually continue to effectively manage your women in terms of cervical cancer screening. So what it is a blended learning. What we are offering is an online module. Now, online module followed by a practical workshop, and then you get a certificate of completion at the end. For all of you who are keen to further in education, then we are also offer training for champions as well. So the first line is an online module, and we know that all primary healthcare providers and all healthcare providers are busy. We don't have time to have long modules to sit down and do modules. So what we have is only 5 foundation of cervical cancer elimination strategy, especially in Singapore. In any kind of training, your foundation has to be strong. So these are only 20 minutes online talk. You do have to take a small amount of quiz just to make sure that you understand that what you are talking about or what you are looking at. And these talks are being delivered by our local HPV-related cervical cancer experts in Singapore. Once you pass the online module, this is the crux of the EmpowerCare program. It is a face-to-face workshop, 3 hours of your time in the afternoon. And what we do is that we bring you in, and whatever theory knowledge that you have achieved from the module, you now clinically apply it in the workshop. And what we're concentrating on is first to refresh your skill in terms of physician sampling and HPV self-sampling. Also, you will have the opportunity to sit down with a local HPV and cervical cancer prevention expert. Most of them are from the SCCPS council members and committee. And what we will do is that we will sit down with you in small group discussions. You'll be able to bring all your cases to discuss with the experts, and also we'll have role playing on how to answer frequently asked questions that is posed to you by women. So things like, how did I get the HPV, doctor? Why is it not going away? Does my husband give it to me? Is he having an affair because he gave me HPV? These are questions that nobody likes to answer, but we can give you the tool and the skill to answer them so that you can manage your women better. And if you're interested, this is the QR code. You can also email the secretary, and we are hoping that we will be able to introduce this program to you very soon. Thank you very much.
Thank you so much, Dr. Ida. Our next speaker is Dr. Bertha Woon. So Dr. Woon is a consultant at Thomson Breast Center with over 27 years of experience, including 18 years as a breast surgeon in private practice. Trained in breast conservation surgery by pioneer surgeons, she developed a strong interest in breast cancer care early in her career. She has been a long-standing council member of the Singapore Medical Association, served on multiple ethics committees, and remains active in national and regional medical associations. Her topic today is screening for breast cancer in Singapore. Please welcome Dr. Bertha Woon.
Hi, good afternoon everybody, and thank you so much for the privilege of speaking to all of you on a Saturday afternoon. Thank you for the very kind invitation from Thomson and Innoquest. And so because I'm preaching to the converted, so even though I do have slides, we don't really need to talk too much about the things that everybody knows. So this is the brief overview I have about the statistics, which I am certain all of you present know. All right? So first of all, why do we screen? Okay, we screen because number one, we want to catch the illness early. Breast cancer, as all of you know, is the number one cancer in Singapore, and it has increased in trend ever since we became independent 60 years ago. And Singapore is so hardworking about screening, that's why we're talking about it. 60% of our patients are diagnosed in stage 1 and 2, all right? And our survival is really good because you all do such a great job as ONGs and as family physicians to do the screening. So I want to applaud all of you, okay? So the statistics you can read is from our national registry. So anyway, it has gone up, but I want to bring you to the attention of the critical illness plan. All of you are in a very good position to inform all of your patients, please buy your health insurance before any doctor finds anything in you. Otherwise, you know the tragedy that I encounter as a breast surgeon is that young ladies go for so-called free screenings, right? They go for these ultrasound tests and they find one single cyst. And then forever after, for the rest of their life until their mid-80s, breast is completely excluded. So please remind your patients, if they have not bought their insurance, don't do anything. Okay, just don't do anything. Do your breast exam and say, okay, no lump palpable, please go buy your insurance first. Okay? So it's hospitalization and critical illness. Right. The next thing is about self-exam, but before that, I wanted to show you, this is 2013. At that time, I was talking to the Ministry of Health about how come we are seeing so many young people with breast cancer before the screening age of 40. Now, this is very troubling because we have a low birth rate already, right? We are below replacement level. And yet, if you look at this breakdown, this one is, look at the 30-something to just short of 40. Can you see the age-specific rate going up? And this is from 2013. How scary is that? That is the age where all of you ONGs are busy helping people who want to make babies, right? So therefore, please remember to screen your patients. Okay, so number one, make sure they have insurance. Number two, before they get pregnant, please screen, all right? So this is critical. We want people to make babies. We want to replace our population, right? Now, these are the risk factors that everybody knows from our school days. Now, all those that I put in asterisks are the modifiable ones. So you know in Singapore we have Healthy 365, right? We encourage everybody to exercise. I'm sure all of you in private practice knows that your patients are normally very motivated, otherwise they don't see you in private practice, they will be in the restructured system, isn't it? And everybody in private are the hardworking, exercise 3 times a week, don't smoke, don't drink, eat low carb and don't know do what, exercise all the time. But can you see, no matter what it is, our increased rate, if you look at the National Disease Registry, it keeps going up. So, and then there are all these people about genetic risks. I just put this up because this is available on any textbook and Googleable. But the critical problem in Singapore is, ever since independence, do you remember our 2 children only rule? There are very few families where people actually have a known family history because the family is so small. You can ask questions and you get, oh, I have no family history. Of course not, the family is too small, right? So you will not get a history. So therefore, all of this is good for textbook, but in your real life, on a day-to-day basis, too bad, doesn't help a lot. Okay, and then this one, I put it up because I'm aware that all of us are informed, oh, you must ask the family history of breast and ovarian cancer. But I put this up just as a summary of all the other cancers that can also be associated with breast cancer. And this is helpful to us when we take history because the families are so small, right? You think, oh, my grandfather had prostate cancer. You think it's not relevant to breast, but it is. So you look at all this and just think about it. Like for example, BRCA1/2 is our common breast ovarian. Then there's also pancreatic, prostate, and melanoma. Right? That's purely BRCA1 and 2. Then you have this hereditary diffuse gastric cancer. So sometimes people tell you, oh, my grandmother had gastric cancer. You will ask what kind, and then lobular cancer is really difficult to detect on a mammogram. So, so esoteric, but nowadays getting more common. So good to know, right? Then, for example, P10. So someone tells you, oh, my first auntie had thyroid cancer. Doctor, is it relevant to breast cancer? Well, yes, it could be if it is a P10 gene, right? So similarly for the TP53 and PALI2. So the purpose of this slide is just so that you don't discount all the other cancers that you're asking about. All right, don't just limit yourself to breast and ovarian. Now, exam. All of you are very hardworking. I know because I receive a lot of very pertinent referrals from family doctors and OMGs. Now, the chief trouble with breast examination for all of us is, one, your patients only have their own pair of breasts. Okay? So, if they don't do the exam, they will never be able to tell you if there is a change. And you also only see them at one point in time. It depends on which part of the menstrual cycle you see them in. If you happen to see them near menses, you'll be tender, you may be more lumpy or whatever. So what I do is I tell the patients, examine at day 10 to 14, least painful time, right? And more likely to feel something that is a problem. If you take it too near menses, then you may have all these false positives, which in the end, when you do your imaging, there might be nothing. All right, so here we go. These are typical things that we teach our patients. Now, the biggest problem is when they are big. All right, so people who are quite small, different cup size. All of you are ONGs, and family doctors. Different cup size. If you were cup A, it's very easy to feel something, right? You might even mistake the rib for a breast lump, right? But for people with cup D, there is a huge problem because it's like Princess and the Pea. For those of you who have read the childhood fairy tale, right? If you have 50 layers of mattress and you're trying to feel one pea, you can't feel a thing, right? So, you can tell the ladies to feel everything and always remember to feel behind the nipple because I just took out a 3 cm mass from a lady's retroareola because she did a self-exam every single month, never felt behind the nipple until she went for a massage. Someone massaged her back and she had sudden onset pain in the nipple. And then that was when she discovered, oops, there is a lump behind it. Okay? So all of this, you have all attended a lot of CMPs. It's 3 fingers together, the pulp, and draw circles, right? But the trouble is, the nerve endings can only allow you to feel anything 5 millimeters and above. So by the time you can feel something, it's usually not early, right? Which is why we need to do screening images. And then you need to tell your patients, why do you feel? Because all of you have patients who want to get pregnant, right? They have lactational changes in pregnancy. The reason you need to feel is, number one, are you symmetrical? Not everybody is symmetrical. Do you remember when we were in utero, right? As an embryo, the fusion line is here, right? So left and right will never be identical, right? So a patient must know which one is bigger, right? They must look in the mirror, tell you, Doc, my left is bigger than the right, or the right is bigger than the left, or which one has more tissue. So they need to know the normal so they can tell you what's abnormal. Number two, they change with maturity. You are the best people in the room to know about this, right? Adolescents all the way up, the breast shape and size will change. So they need to know what is their normal. And thirdly, even part of the menstrual cycle, I have patients who increase one complete cup size during menses and then shrink back after menses. So that's the reason why we list for mammogram and ultrasound mid-cycle, less painful, higher uptake. If the lady does not hurt during the mammogram, they are more likely to do regular screening. If you go and disregard the timing, send them at the point of menses, and then they have the clamping, they call it, right? Suck. And after that, they will never screen ever again. Alright, so mid-cycle. And then also, some of my patients are diagnosed with breast cancer when they do weight loss. So some of these people, they go on high rocks. Have you heard? High rocks, don't know whatever triathlete training, lose one entire cup size and suddenly can feel the breast cancer because they lost all the fat. Right? So you need to know all of these. Okay, yeah. So these are things that all of you know. By the time you get a skin changer, it's a bit game over. Not very good. Texture. So I had a patient, completely normal mammogram, completely normal ultrasound, just a difference in the consistency of the left and the right breast, because the part that felt firmer, like when you cook jelly, right? You have agar-agar, then you have konjaku. So her one side felt like konjaku, the other side felt like agar. And then when we did the MR, it was completely, every single milk duct, DCIS, had not become a mass. So therefore you need to know their consistency. This one is critical. The liver discharge usually is from intraductal papilloma. Cancer is a bit rare. Then breast pain. A lot of ladies, they are now doing weights. I'm sure you have patients who do weights. They go and do a lot of weights and then they tell you that breast pain, but actually it's musculoskeletal. Okay? Right. Okay, this one is a gross photo. I put it all together so that it won't gross people out. So you can look at inverted nipples, peau d'orange, and all this. By the time you get this, it's too late. That's why we must do screening. Okay? Okay. Now, you are all in the position to save a lot of lives. I know that you send your patients for mammography and ultrasound. Now, our chief problem is in the restructured system, they don't allow people under 40 to have the mammograms. Right? So none of the patients can actually request. So you are the gatekeeper. You can help someone. If the patient says, I feel something different, can you please order a mammogram and ultrasound for me? You are in the best position to order for them because we are in private practice. We are not obliged to 100% follow guidelines. If the patient has any sixth sense that something is wrong, please help them and order it. Okay? So this is we have all this population screening because of economics. It's not because of biology, right? We know that HPV only says 50 and above. By the time you do 50 and above, you have missed the entire bunch of people who get breast cancer way before that. All right? So we are doing a disservice if we just adamantly follow guidelines. Then I was told, my patient said, stage 4, came breathlessness, went to see recipe. Oh doc, I have breathlessness every time I walk. Metastasis to the lung. So I asked her, how come stage 4 never go and do mammogram? Oh, because BSS sent her a letter and said, you are encouraged to go for your mammogram. Did not say compulsory. So typical Singaporean threw away the letter. Never did it because DD cup. She was a DD cup breast. Chinese, okay, not other race. Chinese with a DD cup, the mass was inferior. So her breast folded over, so she couldn't feel, she never feel, I don't know how she can miss 6 centimeter CA. Okay? So, opportunistic is for all of you. My gynaes are very helpful. They will always say, oh, by the way, did you have a mammogram done? Then if the lady didn't do it, they will just opportunistically order. Okay, so you will save a lot of lives if you just opportunistically order and check it. Right? So these are the guidelines that you all know. And what we are always aiming for is here. Before stage 0, before invasive. Because If you can catch that person right before DCIS, that person is cured. Alright, so what we see on mammograms, when it is microcalcifications in the cluster, pleomorphic, those where we biopsy, as long as I get the ADH, I'm very happy. Okay? Once it's ADH, it means there's no chance to become a DCIS, right? So it's similar to you all being hardworking about your cervical cancer screening. If we can catch it here, that is cured, alright? So this is some more, we are, lead time bias and etc. We shall not go into it. Alright, so notes for all of us in private. Different X-ray departments have different quality of imaging. So all of us, Thomson has 3D, right? How accurate something is, number one, depends on their machine. So you should always look for digital subtraction if it's a 2D, okay? 75% of our ladies have dense breasts. So for those people who are under 40, dense breasts, and you need to evaluate, 3D is the way to go, alright? The other thing is, if you don't happen to have a 3D, you can always add the ultrasound, because if you add the ultrasound, you get about 4% extra detection rate. Not all breast cancers will be seen on a mammogram because there are at least 25 histological subtypes, right? Our garden variety is invasive ductal. Sometimes certain cancers like mucinous, you can't really see on a mammogram and you need the ultrasound. And that is why this very labor-intensive ultrasound is one of the things that we add in private practice because we are able to and the patients can afford it. Alright? And then when you go for the screening, please make sure that the X-ray department gives you both the report as well as the images. Because, when they draw a diagram for you, you're converting a 3D breast into a 2D diagram and you can't actually tell based on measurement or based on shape that they draw whether it is really a problem or not. Okay, so please ask them, give you the image. Do not accept it if they just give you a report. And especially if they give you a report with no radiologist signing on it, please request the proper report so that you know how to compare one against another, like year on year, okay? Right. So, why do 3D? For greater clarity. Ever since 3D appeared, I seldom do 2D, okay, except for those which have very non-dense breasts. Fewer false positives, breast density is solved because 75% I told you, we have dense breasts. And then less pain and more comfort and improve your cancer detection. So this one is just a picture. So the line on top shows you the actual tumor, right? And this is the differing types of density that we have in our population. As you can appreciate, if someone is extremely dense, you cannot see this thing against that. You know what I mean? So that is the reason why density is important, right? Do a 3D. Okay, this is 3D tomo and showing you this architectural distortion, right? That's why always ask the X-ray department to give you the images so that you can give it to the patient for follow-up. Okay. Fear factors, I already said, how to reach target audience and the fear of pain, right? So I already told you time of the menses and also how experienced is the radiology department. So as a breast surgeon who also has to go for screening, I have had my breast tapped at different X-ray departments, okay? So the difference in the pain level depends on the person who is doing it for you, number one. Number two, how fast they put the clicker. It's like you clamp and then some of them take their own sweet time and walk off and then take a picture. That kind for sure will be painful. Okay? So I already have a list of where does not hurt much, right? They all hurt. It's just the degree, okay? And some of them, they give you a little foam to pat, especially if they are AA cup. So the people who hurt the most are the very small ones and the very big ones. Okay, all the intermediate sizes don't hurt much, right? So if you see that you have a patient who's quite small, please send them to a friendlier department. Okay, I will tell you can PM me and I'll tell you which one. Okay, so fear of course, okay, never mind. This one, there's BSS. Right. The trouble why we cannot do ultrasound commonly is because it's very labor intensive. It takes about an hour for a thoroughly done one. Okay? So I have patients who've had it done in different departments and they tell me which department is better because who is more thorough. Okay, so the accuracy of your ultrasound depends on who is doing it and how thorough they are. Right, so we therefore do not use it for routine screening. Okay, these figures are not helpful to frontliners, so it's just in case you want to know. Right, yeah, and MRI. So MRI is a super expensive modality. One certain department does it for half price at day 10 to 14 for people who require screening and can't afford it. The reason you can do an abbreviated one is only because it's day 10 to 14. Okay, if you want to know who, you let me know. Yeah, I will tell you. But basically, some people, you can't follow up because they put stuff in themselves. So that they go all over the world, right? Oh, they go on holiday, someone tells them, put a filler. Once they get it, you're stuck. Right? So you need to do MRIs. And some people, it's because they are so young and so dense that nothing can be seen except on MRI. And that's why you need to do an MRI. But this is not routine. Now, there are some other imaging techniques which I don't normally use, right? But it is available. In our country, we have contrast enhanced. That one is like a cheaper version of an MRI. They inject iodine contrast. Okay, I've only used it once, to be honest, right? Because normally for breast surgeons, we do MRIs to do 3D planning of whether we can conserve the tumor. Okay, then there are all these special groups and high-risk women. So people with family histories, we start 10 years younger than the youngest person in the family with the cancer. And we have a huge problem right now because my youngest cancer patient is 17, right? So we do not know what's going on. I'm not sure what you have encountered, maybe you can let me know later. But my friends and I in private have seen the ages of our breast cancer patients getting younger and younger and younger, and we do not know what's going on, right? I'm sure you have encountered in your life. So nowadays, anybody who tells me, okay, I feel something, I think it's different, I just scream. Okay, I don't even second guess them. Right. Okay, so now I'm honored to inform you that InnoQuest has come up with this test, has been used in Korea for the last 2 years for their population screening. MastoCheck is a blood test, so this is like to overcome people who do not want to go for mammogram. Most of the time, I will persuade my patient to go, all right? Now, there are some really stubborn ones who flatly refuse to go. So from next year, February, there will be this blood test that InnoQuest will do in-house in Singapore. And it's called MastoCheck. So this one is for people who, number one, don't want to mammogram, or two, don't have the ability to go for ultrasound. And the self-exam, you can't feel much because lumpy, born lumpy, or just too big, you know. So this is a test that uses 3 specific breast cancer protein markers. And these markers are CHL1, ApoC1, and CA1. So what happens in Korea is because they have a population 65 million, right? So when you have to screen a population that big, it is really not very practical to say everybody must go mammogram, ultrasound, whatever, right? So they did the blood test, and this was validated in Korea, and they have been using it. So what is critical for us to know is what happens when it's virus 0 and when it's virus 3, okay? Virus 0 is so indeterminate because, okay, you've got this whiteout mammogram. You don't know whether the person has or has not. You don't have the manpower to do an ultrasound. So MastoCheck is a blood test that you can just take and send to the lab, and they will tell you high risk or not, right? Is it something that you've got to follow up closely or not? And then the other one is virus 3. For me, before MastoCheck came out, every time something is virus 3, I will increase the screening interval to 3 months instead of 6 months or a year, right? And because I see it every day, so it is easy for me to tell whether the virus 3 is changing or not. But for you on the ground, who does not see all this kind of thing every day, you might be helped by this MastoCheck blood test, which I'm actually quite interested to know once they come to Singapore. I would like to test it because this will save a lot of time for my patient, a blood test with a result, right? And this is what the results in Korea are. So for them, they only checked mammogram with MastoCheck and ultrasound with MastoCheck. They did not do a mammo ultra with MastoCheck, which I asked. right? So I thought maybe it might be helpful over here, just thinking of how to do a study, right? So you can see the improvement in the sensitivity and specificity that they got in Korea. So this is one of the exciting developments for breast cancer detection. And this is what they do, that you send your phlebotomy. I don't know if, I think in GP practice, the phlebotomist is you, right? So for me, I'm in a hospital, I have a phlebo, I can call up to my clinic to take the blood. And then their turnaround time at the moment is they have to fly it to Korea. But from next year, February, I'm told by Innovest, it will be an in-house test. And the turnaround time will be 5 days. So the cost of screening, as you can see, this is just ballpark. All of you who have been in practice a long time knows that the cost of the mammograms and ultrasounds vary significantly in between different X-ray departments. And that one is one of the cheap considerations. So you need to know what is good enough and what is very good. So for general screening, good enough is what you need, okay? So you can also ask me what is good enough, and I'll tell you, but not now, right? Okay, so the results of screening. So the only things that you ever need to refer to me are when it's Barrett's 3 and above, okay? Barrett's 3 for follow-up, and 4A is suspicious for cancer already, so we've got to start biopsy. Barrett's 3, so what happens is, if you have a patient Barrett's 3, only solitary lesion, then we discuss with the patient, what kind of follow-up would you need? Do you want every 3 months? Some people have a lot of time, some people fly all the time. So my patients who get biopsy are because they are not in Singapore. They are Singaporeans working outside, right? It's hard for them to come home. Sometimes we just get rid of these solitary lesions so they can follow up 1 year instead of 6 months, okay? So it's sort of for convenience sake, not really for a medical reason, but for 4A and onwards, it is for diagnosis. What I normally do nowadays, because it's so early, is called vacuum-assisted biopsy. The first generation was called mammotome, I'm sure you all know, right? Nowadays, we use either the bar machine called Encore Inspire, or we use a Korean machine called Baxcore. The reason there's a difference is because for the Korean machine, you can adjust the aperture size, and you can also adjust the degree of suction, because Asians are smaller than in the West, right? So we need to not suck too much and cut too much and drag the skin down. So because of this minimally invasive way, we can diagnose a lot of people really early before they progress. So just for your information, we do both stereotactic on the 3D machine. So if it's microcal, we use a 3D mammogram, we get the XYZ coordinates and just get the calcium out without having to cause a scar. Okay, and that's also relevant to let you know, because all women will ask me, oh, if I get pregnant, can I breastfeed? If you go and cut across their milk ducts, you will jeopardize their breastfeeding chances. That's why we always do keyhole now. Alright, so in summary, this is it. Please remember, if your patient tells you, oh, I have 4 people in my office all get breast cancer, can I please do a mammogram even if I'm underage? Do it for them, please. Mammo Ultra, right? And yeah, thank you very much for your hard work in being the gatekeepers to save women's breasts. Okay, thank you.
Thank you so much, Dr. Woon, for your amazing presentation. Hope moving forward we can save more lives as doctors. So without wasting any more time, let me introduce our next speaker today. So our third speaker is Dr. Hongdo, Group Laboratory Director of LifeStrands Genomics. Dr. Hongdo is a molecular scientist with 20 years of experience in cancer genomics, diagnostics, and research. He earned his PhD in cancer genetics and epigenetics from University of Melbourne and has held research and leadership roles at leading Australian cancer centres including Peter MacCallum, the Ludwig Institute and the Olivia Newton-John Cancer Centre. He previously served as head scientist at St. Vincent's Hospital, Melbourne and quality manager of NATA accredited lab. Currently, Group Laboratory Director Dr. Do has over 50 scientific publications, is a NATA technical assessor and supervises PhD students at the University of Melbourne. He is highly experienced in ISO 15189 and CAP audits, Today, he will be presenting on genetic advances in non-invasive prenatal testing, NIPT, covering current performance data, clinical cases, and future applications in genomics. Please welcome Dr. Hongdo.
Thank you for the kind introduction. This is an overview of my talk. In this talk, I start with the introduction to the brief history of NIPT. Then I touch on the type of genetic alterations that NIPT can detect, common trisomies, and the sex chromosome inequalities, and then touch on the microdeletion duplication as an emerging marker, which can be tested by NIPT. Then I'll review the current NIPT performance data, focusing on detection rate and positive predictive value with some interesting predictive cases. So finally, I touch on the NIPT report, how to interpret this report when you return to the clinic. NIPT is a screening method which assesses the common chromosomal alterations in the fetal DNA using maternal blood. International guidelines recommend NIPT as a screening method for all or high-risk pregnant patients. The journey of NIPT starts from this very important finding published in 1948, back down to 1948. Two French scientists discovered the presence of cell-free DNA in fetal blood. This discovery laid the foundation for the concept of liquid biopsy. So you heard about liquid biopsy more often nowadays. If you work in the oncology field, liquid biopsy is a common concept to monitor cancer patients, like ESR1 mutation is another emerging marker in cancer, breast cancer monitoring case. Currently, liquid biopsy has been practiced in three clinical areas: oncology, organ transplantation, and pregnancy. So I focus on my discussion in pregnancy. The story in the pregnancy as part of the NIPT, the liquid biopsy testing started from this important, paper. This seminal paper published in 1991 by Professor Dennis Lowe and indicated cell-free fetal DNA is present in the maternal blood. To answer, he asked a very simple question: is a fetal DNA present in maternal blood? So he learned this lesson from the oncology research because he knew circulating tumor DNA is present in the blood of a cancer patient. He simply switched the clinical condition from cancer to pregnancy. So he asked this patient to also he wants to know whether this fetal DNA is present in the maternal blood. He recruited a pregnant woman bearing male fetuses, and then he searched for the Y chromosome DNA sequence in the maternal blood. So he could have found the Y chromosome DNA in both placenta and serum. This is the first paper indicating the presence of fetal DNA in the blood. Now we know this fetal DNA is originated from placenta, trophoblast cell, not from the fetus directly. So there's a gap between placenta and the fetus. The phenomenon called confined placenta mosaicism, which indicates certain changes present only within the placenta, not present in the fetus, that give some false positive and false negative result in NIPT testing. Just because NIPT only detects placenta DNA status, not the fetal DNA status directly. Therefore, NIPT remains as a screening test rather than diagnostic test. So we know the cell-free DNA has got maternal component and a fetal component. And then majority of the cell-free DNA is coming from the mother. Only 10% of cell-free DNA is coming from the fetus. That necessitates very sensitive detection methodology to be able to look at some changes present in the fetal DNA. There's some physical difference between maternal and the fetal DNA, like the size of the cell-free DNA. And also, we know the cell-free DNA is rapidly cleared after giving birth. We have to wait very sensitive detection methodology to be able to answer this minute changes present in the fetal DNA. Next generation sequencing or vector parallel sequencing was introduced to the market in around 2005. This massive throughput screening methodology was able to detect sensitively the presence of the chromosomal changes in the fetal DNA. In 2008, two published study paper published indicating the possibility of this methodology for detection of chromosomal changes in fetal DNA. Inspired by this pilot study, a large international validation study was performed, and the results were published in 2011. In this study, they recruited a patient, high risk for the Down syndrome, and then testing was performed using traditional cytogenetic method. Also, they applied NIPT testing to predict the patient who are at high risk for Down syndrome cases. The result was so remarkable. You can see 209 out of 212 cases were correctly identified by simple blood testing. That is a really eye-opening result, and then since then, this NIPT methodology has been widely adapted and used in clinical management. How many different genetic alterations are tested by NIPT? It starts from common trisomies, trisomy 13, 18, 21. This is common alterations tested by NIPT. So after that, the NIPT expanded to sex chromosome aneuploidies. XO, the Turner syndrome, triple X, the XXY, and XYY. Those four genotypes are commonly tested by NIPT nowadays. Huge amount of data has been accumulated, and then based on this data, the international guideline suggests to use NIPT for screening of these common trisomies SCA. CMV or microdeletion duplication is kind of an emerging marker coming into NIPT testing scope. So there is still limiting data available. Therefore, ACMG guideline only recommend to test 22q11.2 deletion, which is associated with the George syndrome. So we are waiting to accumulate a lot more data until we make some scientific conclusion whether NIPT can be used for CMV detection. Also, you may heard some result about the red or rare autosomal trisomies, which can be tested by NIPT. This red is this trisomy detected, other than chromosome 13, 18, and 21. So, but majority of the red positive results are coming from the placenta. So 9% of red positive results are present only within the placenta and not coming from the fetus. Therefore, this high mosaic rate of the red limits this red routine testing by NIPT. So current recommendation is do not screen for red in routine basis. Let's look at the performance of the NIPT testing for individual markers. As you can see, the NIPT is very sensitive to detect trisomies 21, 18, and 13. But still, we need to remember there is a possibility of false positive and false negative results. Especially if you look at the data coming from the UK, the top table indicates they estimate false negative and false positive rate when NIPT is tested. So we need to, when we see the result, always if the low risk NIPT result doesn't necessarily mean this is free or absent from these common trisomies. There's always low level or rare, but the possibility of false and false negative result. If you look at the PPV value in the bottom table, the ISPD data set indicate the PPV value of T21 is the highest, but 92% chance is going to be really true positive. If you go to the trisomy 18 and then 13, PPV value goes down. That indicates when you receive the trisomy 13 high risk result, that means about 40% of chance it's going to be true, but about 60% of chance it's going to be false positive. So there's a higher chance of false positive for certain markers. This is the performance data for sex chromosome aneuploidy. As you can see, still high sensitivity and sensitivity can be achieved by NIPT. But again, if you see the PPV value, especially for the XO, PPV value is down to 30%. That means majority of high risk for XO cases may be false positive. That indicates the confirmatory testing or follow-up testing is so important for SCA positive result. This is another independent data set indicating the lower PPV value detected in SCA marker. And then the researchers look for the reason why we experience more false positive in SCA markers other than compared to the common trisomies. Then we found some maternal origin of abnormal genetic changes. If you remember the cell-free DNA, 90% of them are maternal DNA, only 10% are fetal DNA. Even maternal DNA contains certain genetic alteration, abnormal genotype like XXX or mosaic DNA that actually affect the performance of NIPT result. Also, we found the placenta mosaicism is one of the reasons for the SCA false positive, especially XO. About 60% of XO result, but false positive is stem from the placenta mosaicism. And also the maternal copy number change present in X chromosome is one of the reasons for false positive SCA result. Now I'm switching to another topic, which is a microdeletion and duplication, which is coming as a very emerging new marker tested by NIPT. I want to review where we are and what is the limitation and what is possible at current stage. About 2% of features, phenotypically normal features, contain this clinically relevant CMV or copy number changes. This change is nothing to do with not associated with the age, different from common trisomies. The size of the CMVs is typically less than 5 megabase, very small in size. Currently, 22q11.2 deletion, which is associated with the George syndrome, has been recommended by ACMG guidelines. Microdeletion duplication occur when segments of DNA is deleted or duplicated. Thanks to the high-throughput sequencing technology, we come to know a lot of more new microdeletion duplication detected in our genome. And we come to know every single chromosome has this kind of a microdeletion duplication. And up to 192 microdeletion has been detected, and then which has been associated with certain syndromes. How about the incidence? Although they are rare, most of them are very rare, but some microdeletion duplications are very frequent and at similar level as common trisomies. This figure indicates 22q11.2 deletion or 1p36 deletion, rather really an Angelman syndrome. Those microdeletions may be as frequent as other common trisomies we normally tested. Due to the clinical implication and also the frequency, and this is ongoing research in the hot topic in the NIPT testing, multiple studies have been published and focusing on the assessment of the performance of NIPT on this microdeletion duplication detection. But the result was not that impressive. Detection rate remains around 20 to 40%, truly detecting the CMVs among the CMVs they tested. And some the figures shown on the top indicate it may be size dependent. The NIPT testing has not been fully optimized to accommodate to detect all different sizes of CMVs. This paper indicates 5 to 10 megabase that CMVs are readily detected, but beyond this size, or smaller or larger, tend to be missed by NIPT testing. So we have very different types of assays in NIPT testing, and then depending on which assay we use, the CMV may be better detected or less detected. This is very early stage in our scientific validation and looking at the performance of NIPT. If the assay miss any CMVs less than 5 megabase, it's becoming real concern. Looking at the George syndrome, which is the most common microdeletion present in the human, The size of the deletion present in this region is less than 5 megabase. Although we call collectively 22q11.2 deletion, this is not a single deletion. Multiple different deletion at different size of deletion have been reported. Looking at here, as small as 0.7 megabase, large as 3 megabase deletion has been reported. To overcome this limitation, some sort of modification has been introduced into NIPT testing. The one modification is fetal fraction enrichment. So rather than testing the DNA fetal fraction at 10%, we enrich fetal fraction up to 25%. Using the physical difference between maternal and the fetal DNA, and then we fishing out fetal DNA before get tested. So this is result we obtained in the lab, and we have seen about 2.5 times enrichment can be achieved. Applying this enrichment step, we did a validation study, recruiting about 40 different microdeletions. Some of the microdeletion duplications are tested twice. Therefore, a total of 73 different microdeletions get tested, and then 17, one of them was successfully detected by this kind of improved assay. Have you seen the George syndrome cases in our practice? Yes, within a year of time, since we introduced this improved assay, we were able to detect 2 George syndrome cases within 1 year time in Malaysian cohort. Both had around 3 megabase deletion size, and then both confirmed by low-pass whole genome sequence. This is confirmatory testing for CMV detection. Another common deletion I want to draw your attention is 1p36 deletion. If you look at the figure on the right, if you see the red and the yellow bar, that indicate the size of different deletion happening inside this 1p36 region. Again, although we collectively call 1p36 deletion, this is not a single deletion. It's very heterogeneous, and many different deletion can happen in this region. So if you're asking how much validation have you done to be able to detect every single 1p36 deletion, practically it's so challenging because obtaining this control sample is very limiting. Also, testing every single different size deletion using the assay with the full validation parameters is very, very practically challenging. Have you seen this 1p36 deletion with our improved assay? Yes. Luckily, we could detect this 1p36 deletion case. The figure on the left and the red arrow indicate the deletion site detected by NIPT testing. On the right, that is the low-pass whole genome sequencing data. We could detect about 15.1 megabase 1p36 deletion in our cohort. This table summarizes the CMVs, confirmed the CMVs detected using our enriched NIPT testing. The size was as small as 1.5 megabase and also as large as 54.4 megabase. Very different size of CMV has been detected. Most of the CMVs were detected as a single genetic alteration. There's one case which had T21 along with microdeletion. CMV high-risk rate was estimated to be 1.7%. Out of 958 cases, there were 175 CMV high-risk cases. Among 175 high-risk cases, 44 of them had a follow-up confirmatory testing, and then we confirmed the 23 as a true positive, 21 as false positive. This is a clinical case where this CMV detection helped the management of this patient. So NIPT testing was performed at week 12, and then we found possible microdeletion present in the 1Q area. And follow-up ultrasound found abnormal features, as you can see here. Multiple abnormal features were identified during ultrasound scanning. Based on this data, amniocentesis was formed at the center for low-pass whole genome sequencing, and the whole genome sequencing result returned with the 1V area duplication, confirming the NIPT result. Because this area deletion or duplication, has multiple clinical features reported, the parents decide to terminate this pregnancy. NIPT results are reported in 3 different categories. The first category is raw risk. When you receive the raw risk means it only indicates raw risk for the targeted aneuploidy tested by NIPT. There are many different genetic alterations not covered by NIPT, including mutations, structural variants, and placental mosaicism that's never been tested by NIPT. Therefore, low risk result does not guarantee the fetus is unaffected. There is a possibility of false NIPT negative result as well. For that reason, current guideline indicate if fetal abnormalities identified from other testings, diagnostic testing should be considered. The second category is a high risk. High risk case are highly recommended to do comprehensive ultrasound evaluation followed by diagnostic testing to confirm NIPT test. There are a few commonly used diagnostic testing, including karyotyping, qPCR, and microarray and robust whole genome sequencing. And then genetic counseling should be considered to provide to the affected family. The table shown here is the follow-up rate. In our lab, we provided free confirmatory diagnostic testing and then free genetic counseling. And then we could follow up how many cases actually did diagnostic testing. As you can see, the follow-up rate is around 40 to 60% for the common trisomies and sex chromosome aneuploidies. The CMV follow-up rate remains at 25%, which is the lowest, possibly due to the lack of awareness that the new marker has not been fully introduced into the clinic or may not be aware of this, the clinical implication of the CMV positive result. The qPCR is a simple technique. You can get the result within 3 days. So if you have any positive result or high risk result for chromosome 13, 18, and 21, and XY chromosome, you can consider qPCR as very quick diagnostic test. Another commonly used diagnostic test is karyotyping, which is a very useful technique to visualize the chromosome and count individually. Also, it can provide some gross chromosomal changes like translocation or inversion or deletion. Also, I want to mention karyotyping as tool for mosaicism detection. Mosaicism can occur when there's different genotypes present in placenta or fetus or both. Especially when you receive the XO genotype or high risk for XO cases, XO seem to be associated a lot more with the mosaicism. Typical XO, which indicating only one X chromosome, lacking another X chromosome, is present about 40 to 50% for Turner syndrome. The remaining 60%, 50 to 60% of Turner syndrome are associated with some sort of a mosaicism or certain abnormal chromosome changes. I want to show you some examples we identified in our clinical cases. In this case, the NIPT reported as an XO. It's an ultrasound confirmed this is male phenotype. So it's different from XO genotype. When we tested this case using qPCR, it turned out to be XY, indicating Y chromosome is present. It tells me the ultrasound result, but it doesn't tell me the NIPT result. And the karyotype result returned as XO. It's quite puzzling. So which one is right? What is wrong? How we interpret this one? So we did a follow-up study to look at the specific gene called SLY present in the Y chromosome. And then we found that this is mosaic case. About 7.5% of XO cells contains extra this gene, SRY gene, in the cells. The remaining 92.5% of cells is having Turner syndrome XO. So when baby is born, the baby is born with a sex differentiation disorder because of this mosaic cell. Although it's a raw 7%, 5%, baby is got affected. This is another mosaic case we found in the fetal DNA, and NIPT report is XO, and when you did the qPCR, the ratio is very abnormal, indicating possible mosaicism. The karyotype result returned as XO, the mosaicism. 30% of cell had XO genotype, and the remaining 70% of cell had one XP arm deletion along with the normal X chromosome. So this result indicates mosaicism can occur in association with the Turner syndrome. The last category in the NIPT report is inconclusive result. So inconclusive result can occur due to the gray zone. So unfortunately, the high-risk result and low-risk result, the result are not fully separate. It's not black and white. There is a zone overlapping area. Both high-risk data and then low-risk data are present. This is called the gray zone. About 1% of the data may be falling into this gray zone. Also, low fetal fraction can occur, especially high BMI cases. Also, IVF-assisted pregnancy, we haven't seen low fetal fraction data. Also, when mother is diagnosed with cancer, some multi-chromosome aneuploidy may be detected because cell-free tumor DNA may affect the result of NIPT testing. Few studies indicated the inclusive data is not just because of lack of information or failure to generate information, is a higher instance of having aneuploidy. So when you get the inconclusive result, the patient may have a higher chance of having aneuploidy. Therefore, current guidelines indicate comprehensive ultrasound evaluation and the diagnostic testing should be considered for inconclusive cases. In summary, NIPT is a highly sensitive screening method, but this is not a diagnostic test. So both false positive and false negative results can occur. Whenever it's medically permissible, confirmatory testing should be considered. Thank you for your attention.